Great presentation. It was really interesting to hear. I'm really impressed by the fact that there's really two distinct phenotypes, which overlap obviously in MSA, the cerebellar and the more Parkinsonian phenotype. And it seems hard to have two patients who could be similarly disabled but respond positively to a completely different set of questions, especially if you're looking at like drug mechanism early on, as Dr. Schenk was saying in his talk. Can you imagine, I mean, how do you think, just maybe you could elaborate a little bit on how a scale could sort of deal with these two distinct phenotypes and yet sort of give a common score which you could translate across patients with the two different phenotypes?
Well, I think that the UMSAR that has been presented and the data, we had a question about does one phenotype versus the other as a different rate of progression, and I think that it has been presented that in fact no, it might be just the same thing. So if you go for a clinical trial, you might use a global scale, and if you are looking at slopes, so you can pre-specify, stratify, whatever, but I wouldn't see it as a major problem. What we have been doing with Werner when we have been testing Rosagilin is that we selected MSA-P for the trial to cope with this, so that's another option. And on the other hand, if a scale is going to be used for different purposes, one is for a registry to describe the natural history, to describe the patient who are in the database that can be who can be used for other purposes. I think you need a global one that is not exclusive. And if you are, on the other hand, developing a drug that is going to be, in your hypothesis, specifically efficacious on ataxia, then maybe you would then choose the SARA and a specific scale. So these scales are existing. They're also in the recently published trials comparing the UPDRS activity of daily living and UMSAR functional activity or whatever. There is some parallelism. So I think there is no ideal solution, but we can cope.
But I think also what you can do is, one of the reasons to include a functional aspect of the scale is that the functions really should be affected by either the Parkinson type or the cerebellar type, so that you would have that secondary co-outcome, as the FDA is now calling them, which would give you an indication of change that may not specify whether it's due to the P type or the C type, but it does affect function.
I think, Andy, what you're concerned about is that some items will just be floored out or ceilinged out in one phenotype versus the other. And I'd be curious to hear what the statisticians in the room would have to say about a scale in which you can declare the phenotype that you're following and then have alternate menu items for parallel functions, weight them differently depending on if they're MSA-P or MSA-C. Given what Glenn said, one of the things we both participated in was a symposium I ran last winter on what are the commonalities across neurological diseases, because all the functions are affected differently with Parkinson's, Alzheimer's, ataxia, et cetera. They're all the same functions. So the functional aspect is sort of easier, but the signs of the disease, you could select which signs you're going to scale for which phenotype.
And in Parkinson's disease, there has been, attempts also for axial symptoms or motor symptoms and motor scores and non-motor scores. So, I mean, with a careful validation process, I think this is feasible.
Right. I think one thing is I'm not a big fan at all of weighting items. I think that there's a real problem with that clinometrically because you don't know what value weight to assign to something. So if instead you look at it as perhaps having two subscales within a big scale, then you could actually look at one that was designed for P, for Parkinsonism, one that was designed for cerebellar type. The floor effect is going to be present no matter what, and what you want to do is try and gear the scale so that you're able to select those most slight cases, the most mildest of the symptoms.
Werner?
Just a quick comment to Jesse's. As you said, I forgot your word, the nice way in which this was developed. Although it was not up to the current standards when we set out to develop the UMSARs, it was a bit like the UPDRS, but the idea that you just outlined and Glenn pointed to, that was there to try and rate function regardless of where the problem came from the cerebellar side or from the Parkinsonian side. So I think trying to take the UMSARS and improve it clinimetrically, similar to when we set out with the UPDRS, try to improve it rather than making a completely new scale is probably the way.
Maybe I can just add on that because, you know, when we did the validation of the UMSARS, we actually obtained also ICARS ratings and UPDRS ratings, and there was a very tight correlation between the scores obtained from the UPDRS and from the ICARS, regardless of whether they had a mixed motor phenotype or cerebellar or Parkinson. So that suggests maybe that this is not such a critical issue and that we maybe should focus more on the function, which was the concept behind this initial UMSARS version.
Can I switch topics and ask something or say something about the registry? I liked what you said about this PPMI-like initiative. But before maybe getting views about the feasibility, but doing something, setting up a cohort of very early MSA and follow it prospectively and associate clinical and biobank data, I wanted to ask Wendy to maybe comment on the common data element approach. Would there be reason for MSA to initiate something like the NIH has done in several contexts, I understand?
Yeah, so NIH has set up common data elements for multiple different neurological disorders, and I think several people in the room have been involved across different diseases. I think at the moment we're not adding new diseases, but if there were an effort amongst a group to develop common data elements, then we could incorporate them into our website and have them available. So I don't think right now we have the funding necessarily to start a whole new disease area, but certainly we can add MSA to the list. One thing that would be good to do, though, is perhaps a subgroup of people who are here to take a look at what's available currently on there, because there is the Parkinson's common data elements, and within there was a non-motor group run by Ron Pfeiffer, and they have a whole set of things which I think could be directly applicable for using for MSA. And certainly I think it would be a wonderful first step to have a common methodology to collect the data so that it can be shared across sites. So I think we certainly can discuss it internally. I just don't know right now that there's funding, but if there were a way to do it, we could help facilitate it and certainly then make it publicly available on our website. And just in terms of things that are copyrighted, we can't post copyrighted scales, but there's always information on there as to where you can obtain them. So certainly I think it's worthwhile for some folks to take a look at that and see how much of it might be directly applicable and how much more would need to be done.
Which illustrate, I think that, I guess this is going to be the last part of the day, that all the things that we have been discussing in the different working groups, we will have to think how to develop this in the near future and what are the priorities and what are the reasonable goals and what are the strategies. But I'm sure that this is what Ryan will be discussing.
So maybe just one last comment, and thanks Olivier for putting and sharing this. My feeling is that there may be a lot of details that we did not work up, but it's clear that everybody agrees, and this meeting is an example of that, that there's strength in numbers and that there's no way that we can continue isolated in different countries or different continents, and the natural history has to be a worldwide project. And I think if we can share data with the French, we will be able to solve MSA, because it's much more difficult to share data with the French than to solve MSA. So this is the first step. This is absolutely the first step to do that. And if we achieve that...
The Austrians.
No, the Austrians are much easier. The Austrians are much easier.
We don't have that many subtypes of cheeses. That's why we're easy.
So we learned that, and we are all certain that, again, like a great French author Alexandre Dumas says there is strength in numbers, and it's either united, we are going to survive united, or die not united. So I can't remember exactly, it's the Three Musketeers line. You probably... Correct. So I think we can solve the details. Look, a natural history study, we can talk for hours, but at the end of the day, we all agree which is the data that we have to put together, and what are the biomarkers and the clinical data. There's no argument with that. I mean, some of the arguments that we have are only semantic, guys. And an example is Jesse and Neil Quinn arguing about exactly the same things. I mean, we know that diagnosis is not something that occurs in the first visit. Sometimes it does, sometimes it does not. This is in a few more visits or with time that you are certain about diagnosis. So we all agree with that. In terms of the natural history, I think we also agree what we have to put together. The big thing, what we have to decide, is whether we just do MSA, which would be an easier first step, or we start, like we have done in the consortium, with other features like orthostatic hypotension, REM behavior disorder, cognitive difficulties, this real pre-motor, if we could do that. And eventually, I think we're going to get to that point, but perhaps starting with a minimal data set of MSA is the way to start across countries.
Well, it's interesting because MSA is a multi-system disorder. So you see it from, so you would like to put orthostatic hypertension or pure autonomic failure, etc. Those from the cerebellar world would like to include all the different ataxias. Those with the Parkinsonian aspect would say, well, PSP is, also not sharing alpha-synuclein, but a number of functional issues. So, if you add all these disorders plus France, then it's going to be complex.
Absolutely, yes.
Okay.
And the next meeting is going to be in Toulouse, you know that, because Olivier is organizing it, the next MSA group.
Oh, one question.
From the biomarker working group, we'll talk about it later, but I think maybe it's a good time to bring this issue up. I mean, from our work, I think what needed is a population. It's a well-defined population. So that's clearly missing. So we're dealing with the couple dozens, the best scenario, and then we report a biomarker, and often that cannot be or can be replicated by the others. Mm-hmm. Is that the issue of the heterogeneity or something else, right? So I think in a way, if we could, as you suggested, put together an international consortium, and with the population well defined, with the common data elements collected clinically, with all those biofluids collected with standard fashion, then we can talk about the biomarkers. Otherwise, we're comparing apple to orange.
Which is what is the PPMI project in Parkinson's disease, which means that this is a type of registry where you need a limited number of centers with good training and certification for diagnosis and access to a minimal technical environment for, wet biomarkers and imaging. On the other hand, my understanding of those who are, in genetics, this is not going to be enough for them. What they are looking now for is the largest possible numbers. So in that way, they still want to be sure that they are going to be dealing with patients with MSA, with all the limitation of the predictive value of the diagnosis, but then this might be, a different kind of a network. We could think about a registry of 3 different levels and then apply it to different centers according to different initiatives and projects.
I mean, I think in the NIH already has done great job in that sense. Like a PDBP program that we involved, I think the water is the kind of the champion on that. So that's something all can be followed in a way. There's a basically template that you can just follow. Just saying, okay, you have done great job already. We just tag along.
Well, we'll discuss with the working group on markers, but I think that we have enhanced what we need. We can always improve it. I think the only thing is to set up a consortium, to apply for the funding, because you need the power, that many patients, as good as possible, and if you want to follow them for 5 years, if they are still alive, then you need the cash.
So I think we'll probably come back to some of these issues this afternoon, but it was really great to hear sort of the collaborative spirit on this effort. So thank you to panel 5, and we're going to move on to panel 6, which is chaired by David